And thank you for joining us today. My name is Ashley Moncrief. I am Director of Patient Care at the MDS Foundation. Joining me today is Janice Butchko, Assistant Director of Patient Care. We will be moderating today's webinar. We'll move to the next slide. Before we get started, I would like to provide a brief overview of the MDS Foundation. The MDS Foundation is a global nonprofit organization dedicated to supporting patients, caregivers, and healthcare professionals affected by myelodysplastic syndromes, a group of rare and life-threatening bone marrow disorders. Since our founding more than 30 years ago, we have remained steadfast in our mission to advance research, provide critical education and support services, and improve treatment options for those impacted by MDS. Next slide, please. We have a little bit here about our global reach. Our global reach and impact includes over 16,000 patients served through education programs and resources. We average approximately 400 new patients and caregivers per year. We have 18 different patient resources that are translated into 14 languages, and you can see which ones are available online. We have nearly 1 million website views, 200 and I believe it's now 14 global centers of excellence representing 40 countries. We've added 25 new ones this year. 24 researchers supported and more than $1 million awarded to advance research. Between 200 to 400 professionals that attend our professional MDSF programs, and 298,640 risk computations completed via the IPSS-R and IPSS-M calculators. Next slide, please. We have built a strong global network connecting patients, caregivers, and healthcare professionals with vital resources, education, and support. To name a few, here are a few key resources that are available. Next slide, please. We have in-person education programs. We hold 6 in-person patient and family forums across the U.S. every year. These provide an opportunity for patients and loved ones to connect with others going through a similar experience. They also offer direct access to leading experts, the latest advancements in treatment and clinical trials, and referrals to our centers of excellence, ensuring patients have the information needed to make the best decisions for their care. We also hold an international patient forum every 2 years at our International Congress. We held one this year in Rotterdam, the Netherlands, on May 10th. Webinars such as the one you are attending today, we hold 4 virtual webinars a year on a variety of topics to enable patients and their caregivers access to critical disease and support information without having to travel. By leveraging digital platforms, we can break down barriers to information, reach a broader audience, and empower more individuals to make informed decisions about their care. Educational resources. We offer valuable resources available in print and download for caregivers and healthcare professionals. 2 examples of these are What Does My Bone Marrow Do? And The Building Blocks of Hope. Currently, The Building Blocks of Hope is being updated and only available online until we complete those updates. Next slide, please. Great. So for digital resources, we have our digital programming such as Journey of Empowerment, You and MDS. They offer easy to understand video animations with audio narration, expert video explanations, patient interviews, illustrated slideshows, and educational downloads. We also offer a podcast program, the MDS Patient and Family Report. Clinical trial awareness. We offer a clinical trial matching platform on our website. Many patients remain unaware of trial opportunities or how they work, limiting their ability to benefit from potentially life-changing treatments. Through a comprehensive clinical trial awareness initiative, the MDS Foundation aims to bridge this gap, providing clear, accessible information to patients and caregivers while also supporting industry partners in advancing the most effective therapies for MDS. Next slide, please. The MDS support line provides trusted information, guidance, and support for patients and caregivers. You are welcome to call in and speak to Janice and myself. The MDS Foundation has been instrumental in the creation and growth of in-person and virtual MDS-focused support groups around the world, and we conduct annual patient and caregiver surveys to help guide our programming. I would like to thank all who participated in the 2025 survey. The 2026 survey is expected to be released in February of 2026. Next slide, please. MDS Exchange. The MDS Exchange is a dedicated online community where patients and caregivers can connect, share experiences, and support one another. Whether you're newly diagnosed, exploring treatment options, or caring for a loved one, this forum offers a safe and supportive space to ask questions, exchange insights, and find encouragement from others who understand the MDS journey. Next slide, please. And finally, we host 4 Move for MDS walks across the country that are great opportunities to raise awareness of the disease and to connect with others. We hosted 4 walks this year: Tampa, Chicago, New York, and Boston. The 2026 schedule will be coming out soon. We also have our virtual walk that is ongoing until the end of the year. So if anyone would like to do that, do send us pictures if you can. And next slide. For more information and to access these resources, please visit the MDS Foundation website at www.mds-foundation.org or follow us on social media. Today's webinar is being recorded, so it will be available for on-demand viewing on our website within 7 business days. The live question and answer segment with Dr. Bejar and Dr. Kremenskaya will be available for all participants after the doctor's presentations. You can submit your questions via the Q&A button at the bottom menu bar. Next slide, please. I would like to give a special thank you to Johnson & Johnson, Merck, and Taiho Oncology for supporting the webinar program, and also to everyone who has donated to the MDS Foundation to make these events possible. And next slide. We will now begin today's webinar entitled Disease-Related Fatigue. We are pleased to be partnering with the Global MPN Scientific Foundation, and we are joined by Peter Loffelhart, founder and CEO of the foundation. Today's webinar will include simultaneous Spanish translation. You can select the language by clicking the globe icon. Our presenters today are Dr. Rafael Bejar and Dr. Marina Kremenskaya. Dr. Bejar is a professor of clinical medicine at UC San Diego Moores Cancer Center, where he directs the Myelodysplastic Syndrome Center of Excellence. In addition to caring for patients, Dr. Bejar conducts laboratory research exploring the clinical impact of genetic mutations and epigenetic alterations observed in MDS. As of January 2020, Dr. Bejar has taken a partial leave to serve as the Chief Medical Officer for Aptose Biosciences, a pharmaceutical company developing drugs to treat hematologic malignancies. Dr. Bejar is a member of the International Working Group for MDS Molecular Prognosis Committee and the WHO Classification Committee. He is on the steering committee for the National MDS Study and serves on the Medical and Scientific Advisory Board of the MDS Foundation. Dr. Kremenskaya is an associate professor of medicine, hematology, and medical oncology at the Icahn School of Medicine at Mount Sinai. She serves as the medical director for the inpatient oncology unit at the Mount Sinai Hospital, where she provides medical oversight in the management of hospitalized cancer patients. Her clinical focus is on myeloproliferative neoplasms, acute myeloid leukemia, and other myeloid malignancies, such as myelodysplastic syndromes, chronic myeloid leukemia, and other blood cancers. She works as a part of the multidisciplinary team to provide high-quality, patient-centered care and to ensure the best possible outcomes. Dr. Kremenskaya is actively involved in the development of novel therapies for patients with MPN and AML and is leading numerous clinical trials investigating better treatment options for these relatively rare conditions. She has authored multiple peer-reviewed publications and book chapters. I would now like to turn it over to Peter Loffelhart, founder and CEO of the Global MPN Scientific Foundation.
Hello, good afternoon. First of all, thank you very much, Ashley, for the introduction. So, as I said, I'm Peter Loffelhart. I'm a Swiss living in Barcelona, and I am an MPN patient since diagnosed over 35 years. So I'm very pleased that for the cooperation which we're having with MDS Foundation, and I think it's a very, very good sign that we can make combined webinars between United States and Europe. Our foundation is very active in the MPN field. We are very patient orientated foundation. We want to help the patients to know more about their illness, to advise them how to overcome problems. We want to bring the MPN patient voice to the industry in order that they can look for the right products for the symptoms. And this is keeping us, very busy, and we are very happy with this kind of cooperation. So I don't want to spend more time on this. I would like to give the word to Marina Kremyanskaya. in order that she gives her view on today's topic. Thank you.
Hello, everyone. My name is Marina Kremenskaya. I'm at Mount Sinai Hospital in New York City. And I was asked to talk about fatigue and other disease symptoms in myeloproliferative neoplasms. So I'm going to give some brief overview of the information that we have currently on fatigue, where it comes from, and how to best manage it. So I will talk about a little bit about MPNs in general, different subtypes of MPN, what are the key symptoms, with specific focus on fatigue, and then some of the management strategies. So what exactly is myeloproliferative neoplasm and why is it called that? So it comes from what is described here. So myelo stands for myeloid cells, which is a type of white cells. Proliferative means hypercellular bone marrow, so increased number of cells compared to what you would normally have. And neoplasm, of course, means clonal population of cells. So it starts with one abnormal cell and gives rise to all the other cells. So these are blood cancer with overproduction of blood cells. It's considered to be a chronic clonal disorder of hematopoietic stem cell, meaning, again, the blood stem cells. And there are three main subtypes that we're going to talk about: polycythemia vera, essential thrombocythemia, and myelofibrosis. And it's characterized by acquired mutations, meaning mutations that develop over the lifetime of a patient in these three molecules, JAK2, calreticulin, or MPL, and they drive dysregulated signaling and inflammation. So the natural history of MPNs is demonstrated here. So we kind of think of it as early stages of the disease spectrum. So polycythemia vera, essential thrombocythemia, or pre-fibrotic myelofibrosis. And that is typically characterized more by vascular events, meaning blood clots and things like that, as well as symptoms such as fatigue, itching or pruritus, difficulties concentrating, and many more. And of course, we'll talk about that a lot more. Then it can progress to avert myelofibrosis, or can present as a diagnosis with primary myelofibrosis, or progress to post-essential thrombocythemia, post-polycythemia vera myelofibrosis. And typically patients will have more symptoms. So progressive constitutional symptoms such as fevers, night sweats, increasing in spleen size, often decreased blood counts known as cytopenias. And then patients can also undergo leukemic transformation that can happen from any stage of the disease, but more common from myelofibrosis stage, and unfortunately result in premature death. And just briefly, you'll hear a lot about driver mutations. And these are the mutations that occur in these genes described here. So JAK2, specifically V617F mutation, which is specific change that happens in patients with PV, that is the mutation that is present in over 95% of patients with polycythemia vera. And then a small percentage of patients with polycythemia vera will have a different mutation called exon 12 mutation. Now, if we look at patients with MF, majority of them still have JAK2 mutation, but many will also have calreticulin mutation, and then smaller numbers will have a MPL mutation, and then about 20% of patients have what we call triple negative, so they don't have any of these mutations. And then similar pattern is in ET. They can have any of these mutations or none, and these are called triple negatives. And just a little bit about the natural history of MPNs. If we look at expected survival and median survival of patients with MPNs, unfortunately, as we know, patients may have survival that is less than what is expected survival, and specifically so for patients with myelofibrosis. And of course, we're hoping with all the current treatments that are being developed and already developed that we can make a big difference in these curves so that they get as close to expected survival as possible. So patients with MPNs can have a multitude of symptoms. And so we can start with splenomegaly, which is usually what we have in patients with more advanced diseases, either myelofibrosis or typically more advanced polycythemia vera, rarely in essential thrombocythemia, that can cause abdominal pain, nausea, early satiety, meaning getting full really fast and not being able to eat a full meal, as well as weight loss. Then we can have inflammatory symptoms. We can see that in all subtypes of MPNs, but I think typically more so in PV and myelofibrosis. So itching or pruritus is a well-known symptom specifically associated with PV, but again, we can see it in all of them. And then bone pain and fever is usually in more advanced disease, but can happen at any point. Catabolic or proliferative. So just again, general MPN-related systemic symptoms such as fatigue, night sweats, inactivity, or tiredness. And then micro or macrovascular. So we think these are related to changes that happen in the blood vessels. So issues with concentration, dizziness, headaches, lightheadedness, numbness and tingling, difficulty sleeping, or insomnia. And I'm going through this again on this slide just to have a little bit more of an explanation of what happens. So splenomegaly can happen partly because of the reduced ability of the bone marrow to make blood cells, and it results in extramedullary hematopoiesis, which is basically abnormal production of blood, which can happen mainly in the spleen, but also in the liver, but honestly can happen in any parts of the body as well. And especially in myelofibrosis, the myelofibrosis stem cells just like to get out of the bone marrow and go to the spleen. Pancytopenia, meaning low blood counts. So with anemia, we can have fatigue, weakness, shortness of breath. Neutropenia is low white cell count, so vulnerability to infections. Thrombocytopenia is low platelets, so patients can have bruising or bleeding anywhere. Pruritus or itching, we believe this is due to elevated levels of these inflammatory molecules, but probably many different reasons why people have pruritus, which is honestly still not well understood exactly why it happens in MPN. Portal hypertension, so increased pressure specifically in the blood vessels in the liver, and it can be because of the excessive blood production in spleen or liver, and it can cause all of these complications that are listed here. Luckily, not very common, but can happen in those patients that have blood clots that are related to the vessels in the abdomen or in patients with advanced myelofibrosis. So these are prevalence of constitutional symptoms in over 1,000 patients with MPN. This is an old publication published in 2012. Journal of Clinical Oncology, as you can see here. If we look by different diseases, fatigue is the most prevalent symptom described in all three diseases. And then the others are listed here as well, night sweats and itching and weight loss. But fatigue is really, it's just such a ubiquitous symptom in patients with MPN and many other diseases as well. So I took this figure from a publication by Claire Harrison and many others that was published in 2017. And this was an MPN landmark survey. It was a multi-country survey of over 600 patients with MPNs, and then assessed patients' reported symptoms and their effect on their lives. So in this figure, they showed symptoms that were experienced by patients in the past 12 months by disease type. And you can see that the most common symptom is fatigue, that again is seen in all three subtypes of MPN and is very common and is then followed by abdominal discomfort. The study was published in 2017. And then other common symptoms, of course, are all the things that we talked about, such as night sweat, lack of concentration, and etc. And then I wanted to show another figure from the study. And here they focused on most severe symptoms that patients reported. So on scale from 1 to 10, it had to be at least 6. And again, inactivity and fatigue are the most prominent symptoms that are reported by patients. And this is also taken from the study that I was just talking about. And this is looking at work impairment by MPN subtype. So patients, these are all surveys. So patients were reporting, say, symptoms and how much the symptoms of MPN were affecting their work. And so, as you can see here, again, in all three subtypes of MPNs, perhaps more so in myelofibrosis, patients report that it impacts their work, their ability to work. This is a more recent study that was actually just published in 2025, so this year. And so this study compared patient-reported and physician-reported assessment of individual symptoms. And this was a retrospective analysis, meaning that the patients, looking back, of about 4,000 patients with MPNs in the bioregistry of the German study group for MPN. And again, we're looking here at the most common symptoms that we see in MPN. And again, the first one listed is fatigue. And we see it as, again, very commonly experienced by ET, PV, MF, and everything else. And then followed by pruritus, which is more commonly seen in PV, but again, you can see that it's experienced by all other subtypes of patients with MPN as well. Honestly, I was a little bit surprised by how common pruritus is reported here. But then night sweats, weight loss, and pain are the other symptoms that were commonly reported. What was also interesting here, is that if the first row, so the A row, is patient-reported symptom prevalence, and the second one, the B row, is physician-assessed prevalence, as in it's interesting to see that even though for patients these symptoms are very high, for physicians, as they are reporting is what they think they see in the patients, it's significantly lower. So that suggests that it's probably a combination of patients underreporting their symptoms to physicians, but also physicians maybe not taking their symptoms that patients are reporting at face value or as seriously as they should. And I think this is a very important lesson to all of us, especially physicians, that we really need to dig more into patient symptoms. Yes, so important points as I've discussed. And this is from the same paper, and I just wanted to show this quickly. This may be a little difficult to understand, but basically what is showing is that they looked at overall survival of these patients and the symptoms that they reported. And what they showed in the study is that the presence of any severe symptom at baseline, so when patients were first presented, was associated with a higher hazard of death, meaning they were more likely to die. And this was adjusted for all kinds of variables. And severe fatigue at baseline and severe weight loss at baseline were the factors that were most associated with this. So I think it's just another way of looking at this and knowing that those patients that present with severe fatigue really have very severe disease that needs to be addressed as much as possible and as fast as possible. So in general, fatigue is the most disabling and the most common symptoms of MPN. More than 90% of patients report fatigue. In fact, it's probably closer to 100%. It is often not relieved by rest, can have profound impact on quality of life. And it's important to note that even early stage, low risk patients, so those patients that we typically don't even necessarily think may need aggressive treatment, experience substantial fatigue that can have an important impact on their quality of life. I wanted to add this as just an important point. So cytopenias, as I mentioned, is low blood counts. So, and I'll talk about this a little bit more later, but often, of course, anemia, so low red blood cell count, is of course contributing to the fatigue. And then other blood counts often go with it. So thrombocytopenia can cause hemorrhage or bleeding, leukopenia, or low white blood cell counts can cause infection or increase risk of infection. But if we look at this and we graph the normal energy levels, and so we take patients who have severe fatigue and also severe anemia and they get transfused, So you would think if the fatigue is all due to the anemia, once you transfuse them and get them to a more reasonable level, that their energy levels will improve, but patients don't get to the normal energy level that you would expect with the improvement in anemia. And that's because a lot of the fatigue is related to the disease itself. It's not just the anemia. So mechanism of fatigue in MPNs, and of course it's very multifactorial, so many different contributing factors, and I'm sure I'm not even listing all of it here, but cytokines and inflammation, so this is the hallmark of the disease in MF, is that all of those inflammatory molecules that are released and activated and are superactive in myelofibrosis, as well as the other MPNs, contribute to just this feeling of fatigue. Anemia, of course, is a huge contributor. Iron deficiency, so often is the opposite of anemia in some cases, such as in PV. We'll talk about that a little bit later. Could be contributing to fatigue. Metabolism, so this is part of the similar cytokines and inflammation and a lot of blood cell production. Sleep disorders for many reasons. Of course, the other symptoms make it more difficult to sleep, but there's also inflammatory component to sleep disorders, and some of the medications can also be contributing to fatigue itself. So what we learn from patient perspective is that it often is an invisible symptom. So it's even the physicians don't always appreciate the degree of fatigue that the patients are experiencing, but also importantly, for them, for their families, for their colleagues at work, it's hard for others to understand how fatigued patients are. And it's hard for the patients to portray that to the other people. That can often limit work, social, and family activities, and definitely takes an emotional toll. And of course, I don't have to tell that to the patients. Patients, guys, know it way better than I do. But I hope that as physicians, we appreciate this more and more, and as the community of patient advocacy, physicians, and everybody else, we can work on making this more apparent and working on ways of dealing with the fatigue for patients. So there's different ways that we measure fatigue, that we try to measure fatigue. And so there's these different symptom assessment forms. And fatigue, again, as I presented before, it often scores highest of all the symptoms. And it's higher fatigue, TSS, correlate with decreased physical and social functioning. And I think that is somewhat obvious. So if you're more fatigued, you're not going to be able to do as much. And so these are some of the patient experiences of fatigue. Again, this was a description, and I'll talk more about the specific paper. Disable, invisible, dismiss, fatigue dominates daily life. A patient described exhaustion impacting work relationship and independence, and clinicians often underestimate fatigue's impact compared to objective disease markers. So it's easy for us to say, your blood count is low, you're anemic, or your platelets are low, or your spleen is large. But it is the only way we can estimate someone's fatigue is by listening to what patients are reporting. And so it is often much more difficult to fully understand it. So this is the study I was talking about. So this is a study that was published in 2022. And they used qualitative methodology using multiple different methods, and they explored the research question of what is the lived experience of fatigue for people diagnosed with MPN. And they did semi-structured interviews to gather specific stories of people with MPN that experience fatigue, and then they tried to come up with thematic analysis, but also just describe it in the publication. The study was done in Australia. And so they tried to kind of group it together into these 4 categories. Life with NPM, it's not being tired, it's completely different, it's fatigue. It changed your life completely, and living the best life I can. And then they kind of group patients' responses into these categories. And I thought it would be good to share some of the quotes that patients that were presented in the study. It was very eye-opening for me, actually. And again, I'm sure many of you live in this, or maybe some participated in the study. So there's tiredness and there's fatigue. Tiredness can be fixed by going to sleep. Fatigue can't be. You know, you can wake up and you might feel a bit less tired, but you don't feel less fatigued. Another quote, you wake up in the morning and you just feel awful, like you haven't slept at all. I have a lot of energy in the morning. By 3 o'clock in the afternoon, I would just be so spent. And I could not do anything except just sit down and chill. And that just wasn't me. It affects me to the point where I can't concentrate. I'm constantly tired and more muddled up. You know, you're left confused. I can be feeling good and all of a sudden it will just hit me like a ton of bricks. After I have a bloodletting, which is phlebotomy, I always feel a lot better, but I would definitely say, of course, I'm not back. I'll never be back to the person, the levels of energy that I had. And so these are just some of the quotes that are in this publication, and they were pretty eye-opening to me. I do hope that we're able to bring improvement in the fatigue for patients that hopefully can get them back to their selves. So like I mentioned, there's different ways that we try to assess fatigue as physicians, nurses, and other healthcare professionals. So we have the MPN symptom assessment for brief fatigue inventory, promise fatigue score, and then we try to also evaluate how patients sleep, nutrition, medications that could be having an effect on the fatigue, and if we can make any intervention of any of these factors that would help. So medical management of fatigue. So we have many different medications that can help treat fatigue. We talked about different causes of fatigue. And in many patients, it's multifactorial, right? So it's not just one thing, but we can try to aim treatments at the individual factors that are contributing to fatigue. So if we think fatigue is due to the disease itself and the inflammation and increased cytokines that we see in MPNs, and everything else has been addressed, then using agents that address the disease pathophysiology may help. So this is the situation where JAK inhibitors are our best option. So they will suppress all those inflammatory cytokines that cause a lot of the disease symptoms. And some of the JAK inhibitors that we can use are listed here. So ruxolitinib is the one that we've been using for many, many years. We also have fedratinib, momelotinib, and in the United States, we can also use pacritinib. And then, of course, we want to address other contributing factors, such as anemia, which can be huge in myelofibrosis patients. The most straightforward and immediate way is blood transfusions. And so this is not something that we ideally want to do long term. We don't want patients to be blood transfusion dependent. But in the immediate moment, blood transfusion can be very helpful to address fatigue. And of course, we have medications that target anemia. They're not always successful, but it's definitely worth trying. So such as erythropoietin stimulating agent, or luspatercept, which targets maturation of red cell precursors in the bone marrow. Of course, we also know that some of the JAK inhibitors can also help with anemia, such as momelotinib or pacritinib. And there are new drugs in development, so currently in clinical trials that also specifically target anemia. So stay tuned for what comes out in the near future. Patients could also be bleeding and losing iron. So repleting iron can work in some cases. And then we look at other causes of anemia. So sometimes patients have hemolysis, which is breakdown of red blood cells by the body. And sometimes we can address that process directly. Occasionally, patients may also be deficient in some vitamins like B12 or folate, and that can be easily treated. And now I just want to show very briefly some of the data that we have and why we used some of these medications, specifically to treat fatigue. So this is the ruxolitinib and myelofibrosis. This is the initial study that led to approval of ruxolitinib for treatment of myelofibrosis. This was published in New England Journal of Medicine, which is, of course, the premier journal, medical journal, in 2012. So over a decade ago at this point. And one of the key factors that was studied was the effect of ruxolitinib on symptoms in myelofibrosis patients. First graph shows patients that had 50% or more reduction in their symptom score as opposed to patients treated with placebo. And you can see there's a big difference there. So patients treated with ruxolitinib are this yellow-orange line, and the placebo is the blue line. And then same information plotted in a different way in the second panel. And then the third panel looks at some of the specific symptoms and shows clear improvement in patients that were treated with ruxolitinib as opposed to patients that were treated with placebo. So like abdominal discomfort, pain, early satiety, so getting full, fast night sweats, itching, and so on. And so this was the very first study of a JAK inhibitor in myelofibrosis, again, that led to the approval of this medication. And of course, there have been many, many studies with ruxolitinib, but with the other JAK inhibitors showing similar effects. And we now know how to use these drugs very well. Now, I also wanted to show one of the figures in one of the studies looking at ruxolitinib in treating polycythemia vera. So this was also the initial study that led to the approval of ruxolitinib in polycythemia vera. And so this was also published in the New England Journal of Medicine in 2015. And so the study was looking at both hematocrit control, spleen volume response, so improvement in spleen. And this is shown in the graph above. So clearly ruxolitinib was better at controlling these important factors of PV, but also importantly, it looked at symptoms. And so the lower graph shows, again, improvement in those patients that were treated with ruxolitinib as opposed to standard therapy, which was mostly hydroxyurea, in these specific treatment categories. And so tiredness, itching, night sweats, difficulties concentrations were some of the important symptoms that were significantly improved by ruxolitinib. And this is the reason why we know that in certain patients with PV, while we have a few treatment choices, JAK inhibitor such as ruxolitinib is a really good medication to use, specifically for those patients that have like debilitating fatigue or itching. This is a great medication to use. And this is another example. This is actually experimental treatment right now. So rusfertide is another drug that is being currently studied in patients with polycythemia vera. And rusfertide is specifically looking at a pathway that affects iron and availability of iron for red blood cell production in bone marrow patients with polycythemia vera. And what we know is that in PV, the bone marrow just uses up all the available iron in the body, or almost all of it, to make red blood cells, because you need lots of iron to make red blood cells. And as a result, patients become very iron deficient. In addition, we of course treat patients with PV with phlebotomy, where we remove blood, and so that adds to the iron deficiency. And we think that a lot of the symptoms that patients with PV have are related to their severe iron deficiency. And then so using this drug, this is a result of phase 3 study, and these results were just presented in June, is that it shows that this is specifically looking at symptoms. So the first graph here is the PROMIS fatigue, so it's looking specifically evaluating fatigue, and the second graph is looking at all the symptoms as part of the myelofibrosis symptom assessment 4. So 7 symptoms here, and that includes fatigue as well. And so what it shows is that those patients that were treated with rusfertide, as opposed to placebo, had significant improvement in their scores, both the PROMIS fatigue and the MFSAF, so symptom assessment form. And so this is another drug that is in late clinical development right now that specifically addresses, in addition to other things, symptoms such as fatigue in patients with polycythemia vera. So I think this is very exciting as well. There are other measures that we, of course, can take, and I know many of the patients and patient advocacy group are looking in different ways of addressing fatigue through supportive management. And again, I'm just listing it here. I did not go through the data, and there is data for some of this. So exercise, we know that even though patients feel tired and fatigued and weak, if they actually manage to exercise, they're going to feel better, and their improvement, their ability to concentrate, their fatigue will improve. So any exercise, so walking, yoga, anything that you can do, I think is going to be very helpful. And I think this is something we as a community need to really work on. Mindfulness and cognitive behavioral therapy, depending, of course, on the particular situations with each individual patient. Energy conservation. Oh, that sounds a little silly, but I think what it means is that you have to kind of figure out what you need to do and how your day is going to work. And if you have a really important project at work or at home, then some patients just have to, and I know many people do it, they plan their days around. That's not what we want. We want people to just have energy all the time. But I think these are ways that we learn how to deal with the disease until we can figure out even better ways. And sleep hygiene. I think sleep is very important. So doing the right things, making sure you get a good night's sleep so that at least not that lack of sleep does not contribute to inability to the fatigue as well. This is what all of us should be doing, but specifically when we worry about fatigue for patients with MPNs. And just at the end, I just wanted to give a couple of examples. So 58-year-old myelofibrosis patient who has fatigue, night sweats, weight loss, so really not feeling well. Started on ruxolitinib, felt better, started exercising more, significant improvement in overall feeling of well-being. And so again, JAK inhibitors are great, specifically for fatigue. For many patients, they work really well, and then adding exercise. Another example, 45-year-old male with polycythemia vera. So doing okay, but really struggling with fatigue and specifically also with inability to concentrate, what patients describe as brain fog. So like really struggling to like, this is a young patient working full time, has a family, really struggling to get all of this stuff done. And then started on the rusfertide clinical trial and noted significant improvement. So again, this is anecdotal, but these are the kind of examples where we're seeing of patients feeling better. So future directions, there are many, in terms of therapies, medical therapies, there are many clinical trials that are ongoing. Many of them are combination therapies. And many of these trials we are specifically looking at symptom improvements as an endpoint. And then there's different ways of trying to assess and fatigue in patients and figure out how we can use that data to improve it. And of course, it's always about personalized management. Each individual patient has their own issues, their own reasons for fatigue, and needs individualized management. So key takeaways here is that fatigue is the most disabling symptom. There are many different causes, and really holistic management is essential. So combination of medical management and everything else. And thank you so much for your attention. And I'm happy to take questions.
Hello, my name is Rafael Bejar. I've been asked to give a talk to you about MDS-related fatigue, and I'll do so from a clinical perspective that I hope is helpful to you to understand not only where fatigue comes from, but how we interpret it, and in the end, what we might be able to do about it. I'll start with my disclosures, and then an overview of the talk we're about to have. I'll start with an introduction to MDS itself. I think there's certain features about the disease that are helpful to keep in mind when we think about how it might contribute to a sense of fatigue. And then we'll talk about what fatigue can actually mean to you, as it means a lot of different things to different patients. I'll tell you how we think about it clinically, how we actually measure it and try to follow it over time in patients, particularly in the setting of a clinical trial. But more practically, we'll talk about what we think actually causes fatigue, whether it's low blood counts, other physical effects of the disease, the psychological impact of the disease, and a really important role of inflammation in contributing to our sense of fatigue. And finally, we'll talk about how disease treatment can actually contribute to fatigue but at the same time could also help it in the long run, particularly when patients have a positive response to treatment. In the end, we'll talk more about how we can combat fatigue, how we can recognize it, and what we can do about it to keep it in control. So let's start with that introduction to MDS more generally. I like to think about MDS as a collection of blood disorders, really bone marrow disorders, because that is where all of our blood is formed. And MDS share these common features where there are low blood counts. If we look in the bone marrow, we see abnormal cells, or what we call dysplasia, which is where the name myelodysplasia gets its name from. And we have to understand that this is actually a disease caused by genetic mutations that people have acquired during their lifetime. It leads to the overgrowth of these abnormal cells, and these abnormal cells don't do a great job at producing blood cells. And unfortunately, in some cases, they can become so abnormal, they actually become acute leukemia. It's not that rare of a disorder. It affects about 30,000 people annually, although most of my patients have either never heard of the disease before they were diagnosed with it or don't necessarily know anyone else who has it. It's really nice to know that there's a community out there that you can talk to through the MDS Foundation and others to meet more people who have this disorder. It is typically a disease of older folks, people in their 60s, 70s, and 80s, who can also have other conditions that contribute to the sense of fatigue. So let's go back and think about what actually happens in the bone marrow. In the bone marrow, we have these really boring looking cells called stem cells. And these cells have this very unique capability that they can turn into any kind of blood cell that you need. And in fact, they're very tightly regulated. They go through many divisions that end up producing all of the white blood cells, the red blood cells, the platelets, and other support cells that are needed for a normal functioning blood system. But these stem cells also have this other capability. They can self-renew. They can make a perfect copy of themselves. And while that's a good thing because we want our stem cells throughout our life, I'll show you where that capability, that self-renewal capability, can actually go wrong. So let's simplify the diagram a little bit and focus on just that stem cell. That stem cell normally can either self-renew, make a copy of itself as shown here, or divide into a series of daughter cells that end up producing normal blood cells, like red blood cells, platelets, and white blood cells, and so on. But if that stem cell, that self-renewing stem cell, acquires a mutation, it can start to grow out of control. It may grow in more ways than it should. It may start to accumulate in the bone marrow, pushing out some of the normal cells and really kind of taking over. And because it's mutated, when it does give rise to daughter cells that are capable of producing blood, it will carry those mutations into those daughter cells that may affect how they function as well. So one example of that, for example, is what happens in myeloproliferative neoplasms that you'll hear more about later today, where you have a mutation that creates too many of a particular blood cell, whether it be too many red cells, platelets, or white cells, or sometimes all of the above. But in MDS, it's usually the opposite problem. You get a mutation that makes those stem cells grow and expand, but also makes them less efficient at producing blood cells. So people have this kind of paradoxical situation where they have too many primitive cells and not enough mature cells because of the same mutation. And this process can continue, this process of accumulation of mutations. And with more mutations, usually comes more bone marrow dysfunction and fewer mature cells that are produced, more severe anemia and other blood counts that are below normal. And eventually, in some people, it can actually turn into acute myeloid leukemia, what we call secondary acute myeloid leukemia, because it came after the MDS or MPN. So let's use an example. Here is a patient, that could be one of the patients that I see in clinic, a 71-year-old man who has bigger than normal red blood cells and low blood counts that have developed over the last 6 months. When we actually measure his blood counts, you can see the white blood cells in gray, the red blood cells in red, and those platelets in purple are all below the normal range shown in those blue boxes. So this person has low blood counts in all three of these different kinds of cells. And to really make a diagnosis, we have to do a bone marrow biopsy. And when we do that, we notice that there are some abnormally shaped cells, those dysplastic cells that I was telling you about. We see some cells in the bone marrow that are more populous than we expect. In other words, we have too many cells in the bone marrow for what we would expect a 71-year-old man to have. And I'll go more into how that might contribute to a sense of fatigue in just a moment. And importantly, we also see that the patient has increased blast cells. These are those leukemia-like cells, and abnormalities in the chromosomes and in the gene mutations that really clinch the diagnosis. We know that this person has MDS. So let's go back to that concept of having too many cells in the bone marrow, because it's kind of a paradox, like I mentioned before. The bone marrow is full of these blood-forming cells, but the bloodstream is not. It has a deficiency in these cells, and that's because that bone marrow is not very efficient. Here are some other kinds of bone marrows that we can see. A normal cellular bone marrow is what you would expect in a normal person. In a 71-year-old, it should be about 70% fat and about 30% cells. There is a form of MDS where you can have too few cells and more fat, but the more typical MDS is hypercellular, meaning it has more cells than you would expect, and that's much like we saw in our patient example. So why can that be an issue? Well, if you think of the bone marrow as comprising several pounds worth of cells in your body, and then having twice or three times as many cells as you normally have, you really have an overabundance of these cells crowding out the bone marrow that creates this abnormal environment for the normal blood cells to form and grow. And furthermore, it's a large mass of cells that are very metabolically active. They're trying hard to divide and grow, and they're consuming resources, they're consuming energy, and they're very metabolically active. And as I'll show you, that can be a contributor to fatigue, because even if you're not out there exercising, your bone marrow is in overdrive trying to produce these mature cells that it's not very efficient at doing. So let's go back to the question of how people perceive fatigue. And I'll share with you some of the comments that I hear in my clinic patients. Some of them may say, I find it hard to get out of bed. I don't have any motivation to get up and do things or even to get out of bed. Some others might say that they have to take naps in the afternoon. Others really describe it more as a physical weight that they have to carry around. I feel like I weigh 800 pounds, that it's really hard to get out of a chair or move across the room. Other folks, we may be less affected, think, I'm okay normally, but even if I do some minor exertion, then I feel quite tired. Or sometimes I feel tired all the time, even after getting a good night's sleep. And others describe it more as weakness, where they feel like they can't move as quickly or live things as easily like they used to in the past. So it's not necessarily a sensation of tiredness, but more a sensation of lack of strength. And these are all really part of the same phenomenon, this concept of fatigue that people interpret very differently depending on how symptomatic they might be. So how do we actually measure that in the clinic? There are some scenarios where it's very useful to get a very accurate measure of how fatigued a person is, particularly if we're doing a clinical study where fatigue might be a factor that we want to look at. Does the treatment improve fatigue or does it make it worse? How does disease evolution change someone's perception of fatigue? And we've come up with these tools. This is one example of it called the FACT-F, or the Functional Assessment of Chronic Illness Therapy Fatigue. And this is a questionnaire that will give patients where they're asked a series of questions that get at how much fatigue is affecting their life. For example, their physical well-being might be measured by saying, I have a lack of energy. And then you would respond, not at all, a little bit, somewhat, quite a bit, or very much. I have nausea. It's another physical well-being symptom. I have pain. I'm bothered by the effects of treatment. I feel ill. And some of them are more subjective, like because of my physical condition, I have trouble meeting the needs of my family. But patients will score these, will add up those scores, and will use that as an assessment of how fatigued they feel. And in fact, we have a series of questions that are dedicated specifically to fatigue. So these questions here are more along those lines. And the first question is, I feel fatigued. And people can answer how much that relates to them. Not at all, somewhat, or very much. But we ask it a variety of different ways. You feel fatigued is one way. You could ask, I feel weak all over. I feel listless. I feel tired. I have trouble starting things because I'm tired, or I have trouble finishing things because I'm tired. I have energy. I'm able to do my usual activities. I need to sleep during the day. I'm too tired to eat, or I need help doing my usual activities. And then again, some subjective, more subjective terms like I'm frustrated by being too tired to do the things I want to do, or having to limit your social activity because you're feeling too tired. We ask these exact same questions at different time points and get a sense over time of how people are doing. It allows researchers to measure the severity of fatigue and track it and determine if certain interventions, whether it be a drug or physical activity or some other activity, changes the sense of fatigue that a person experiences. And I introduce you to this because I want to share with you some studies that have really looked at this in patients, particularly who have MDS. So how common is it for a person to have fatigue with MDS? And this study that was published a few years ago give us some insight into this phenomenon. And I like it because it compared patients with MDS to patients with other blood disorders like aplastic anemia or a different disease called PNH. And you can see that the MDS patients tended to be a little bit older. They were in their late 60s or 70s on average. There tended to be more male because MDS does occur slightly more in men than women. And in this particular cohort, they were about 50% white. Now, these patients were typical in other ways, that some of these patients were transfusion dependent. Some of these patients have received a variety of different therapies. And some of the patients did no exercise, and some patients did a lot of exercise. So we're really covering a broad range of people with MDS. And in some ways, that can be considered a limitation because it is a diverse population, but it can also be considered a strength because we're really capturing the gamut, the disease, and the types of people who have it. Keep in mind, this is a single snapshot in time. So any one person on this study could have evolved in different ways. People had different treatments, so they might be experiencing fatigue for different reasons, and they might be at different stages of their disease with different disease severity. And finally, it's not a perfect study because not everyone answered every question. And one of the big limitations is, of course, there were some people who were so tired they didn't even want to participate. So we'd be missing some of the people with the most severe fatigue in a questionnaire study like this. But that said, I think it has a lot of value in shedding light on what fatigue looks like in MDS. And this is really the bottom line that when you ask 145 people about their fatigue-related symptoms, you learn that people have pretty severe fatigue on average. In fact, more than 90% of the people experience some degree of fatigue, and on average, that fatigue was severe. What's interesting in this study is they asked all sorts of different questions, some that were fatigue-related, some that were more related to anemia, some that were related to pain, some that were related to mood, and we can compare the scores that people had in these different areas to their fatigue score. And here's what we learned that fatigue was severe, as just I mentioned, that most people had fatigue of some sort, and that on average it was pretty profound. But the anemia related symptoms, which overlap with fatigue but are not identical, were not as severe. The patients had a much higher score, meaning they were less affected by anemia than they were by fatigue. And other measures like pain were only considered to be mildly affecting people. Same is true for other mood symptoms like depression, anxiety, and stress. And this study generally agrees with what we've learned about before, that about 90% of people with MDS will have some degree of fatigue, and that other symptoms like anemia and pain aren't perfect correlates of this. People can have fatigue even if they don't have profound anemia, and vice versa. Some people with anemia may not necessarily have profound fatigue. Now, importantly, it wasn't the disease treatment or whether or not people were receiving transfusions that really determined the outcome. There seemed to be an independent component of having MDS that was associated with some degree of fatigue, because having the need for transfusions did decrease person's perceived quality of life, but didn't necessarily correlate perfectly with fatigue. We'll get more into why that might be the case. Now, the other point is, how well do your doctors appreciate the fatigue that you're experiencing? Do they know how you're feeling? And you can imagine that even a patient of mine, for example, might hopefully be excited to see me on their clinic day. They might make it a point to get up early, get dressed, take a shower, come to clinic, and they might be looking better than they might on a day-to-day basis. So when I see them, they look very happy to be there. They're telling me about how they're feeling, and they're generally going to be a little bit reticent to share how they're truly affected by their disease. So my perception of how they're doing may not be a realistic perception of how they're doing day to day because I've just seen them for that short time in clinic. So this other study examined about 148 patients with MDS and asked them to take these surveys that assess their quality of life. But they also asked their doctors to take their surveys as if they were those patients. They would try to predict what their patients' responses would be on these survey questions. The bottom line is that physicians often underestimated the symptoms and limitations due to those symptoms that their patients were having. Here's a quote from the article. Correlations between patient and physician LASA scores, this was the test that they used to assess quality of life and fatigue, these associations were initially weak and only increased considerably at later visits, meaning that the initial assessment that physicians had about how patients were feeling was very different from what the patients reported themselves. Patients' ratings for LASA energy were significantly higher. Physicians' ratings for LASA energy were significantly higher than the patient's scores. So the physicians were assuming that the patients had much more energy than they themselves reported to have. And physician scores in LASA activity and LASA in general were significantly higher at 6 to 12 months than the patient scores. So physicians, even 6 to 12 months after getting to know a patient, were still ascribing them to have more energy and less weakness and other things than the patients themselves were reporting. So your physician really needs to hear from you how you're being affected by this disease by giving them really concrete examples. Instead of saying, I feel a lot of fatigue, it may be helpful to say, I really find myself napping 2 or 3 times in the afternoon when I never used to do that before. Or I find that I can't walk around the block as quickly as I used to before. I'm having to stop and rest. Or I'm spending more and more hours of my day in a chair than I used to. So these concrete examples will help quantify and pinpoint how you're actually feeling at home, even if it doesn't necessarily look like you're doing all that poorly when I see you in clinic. This will help us understand what you're going through and how best to help you. So what actually is causing fatigue in MDS? I'll tell you, we don't entirely know, but we know it's not just the low blood counts. Of course, low blood counts, and particularly anemia, are big contributors to fatigue. And if we go back to our example of a 71-year-old man with big red cells and low blood counts that developed over 6 months, we know that person is likely to be experiencing symptoms due to their pretty significant anemia. They might have shortness of breath, especially if they're trying to exert themselves. They might get rapidly exhausted after doing even minimal activity. They might be experiencing lightheadedness or dizziness or having palpitations when their heart is beating very strongly or very fast to try to compensate for their low blood count. And some patients may actually even experience some chest pressure or discomfort. Maybe feeling generally weak, again, from that rapid exhaustion that comes with exertion. And some patients report headaches as well. So clearly, there is a big overlap between symptoms of anemia and symptoms that we would otherwise describe as fatigue. And anemia is a big contributor to fatigue. But I'll tell you that there are many patients who are not severely anemic, who have MDS, who do report very significant fatigue. Now, in some ways, it's helpful to know that anemia can contribute to fatigue, as we can usually do something about anemia. Either give a blood transfusion to help improve the blood count, or give a treatment to help improve the red blood cell count and avoid the need for transfusions. These things can improve the hemoglobin level and decrease the degree of anemia, and hopefully make patients feel better. But because anemic symptoms are not necessarily always the drivers of fatigue, fixing the anemia doesn't always fix the fatigue either. So there are some patients who get a big boost after having a blood transfusion. They feel much better. And there are others who only get a mild boost or no boost at all because their fatigue is really driven by something else. So keep in mind, anemia is something we must absolutely address in our patients with fatigue and our patients with MDS, but it doesn't always solve the problem because there are other things that are contributing to fatigue besides low blood counts like anemia. So what are some of those other things? One of the big ones is this concept of inflammation. Now, this word is a little bit vague because it really covers a lot of different kinds of processes that happen in the body. It's a broad term, but it generally talks about activation of the immune system in one way or another. There are certain molecules that are secreted by the immune system that can have really profound effects on the body. And I'll give you some examples of that. Some of these are localized to one area, like the swelling and pain of an inflamed joint. It just happens at that joint. And some of them are more distributed throughout the body. Things like, for example, infections that cause fevers, chills, fatigue, flushing, and sometimes loss of appetite. So think about when you might have had the flu or a severe cold. You might feel weak all over. You might feel very tired. And that isn't necessarily the infection itself, but it is largely your immune response to that infection that's causing inflammation, and it's causing these symptoms that can be perceived as fatigue and truly are. Many of these immune molecules that drive inflammation, either in response to infection or other things, are called cytokines. And we find elevated levels of many cytokines in patients with MDS. We think it's really part of the disease process. So we can track some of these cytokines as shown here on this plot. And what's interesting is that these cytokines start to show up even when people have very mild or early MDS. You can see elevations of certain cytokines like shown here, like IL-6 and IL-8 and IL-1 beta. And these are primarily driving inflammation in the bone marrow, but it can have systemic effects throughout the body. There tends to be an evolution of the inflammatory processes that occur as people go from early MDS to more advanced MDS, but we understand that it's a really central hallmark of the disease. So this is a very complicated diagram that I'm showing here that describes how all sorts of different cells in the immune system interact with the abnormal mutated MDS cells to produce this inflammatory environment. And we think one of the reasons that these MDS cells do this is because the MDS cells are more resistant to the effects of inflammation than their normal counterparts. So the normal counterparts either go to sleep or recede or decrease their function in response to this inflammatory environment, but the abnormal cells continue to grow and thrive at their expense. And that's why having this inflammatory environment might benefit them. But it also translates into these symptoms that we talk about and that we also can perceive as symptoms of fatigue. Other observations between inflammation and MDS that we notice is that there are certain inflammatory autoimmune conditions like Crohn's disease, ulcerative colitis, rheumatoid arthritis, lupus-like syndromes that occur more often in patients with MDS or diseases like CMML that are very closely related. And in fact, in the last few years, we discovered a new disorder called VEXAS, which is an inflammatory condition that was actually caused by a mutation that's very similar to the types of mutations that we see in MDS. And when we find VEXAS, about half the people that we discover with it actually do have MDS. And there are some people with MDS that we later discover have VEXAS. So there's a strong interaction between this inflammatory syndrome and this disease of the bone marrow that favors this inflammatory environment that we find quite often. And I think this is an underappreciated driver of fatigue, that even in patients who don't have very profound anemia, they do have this inflammatory process in the bone marrow that's packed full of these too many cells that are crowding out the normal cells and are creating this environment that is more prone to causing these fatigue-like symptoms. What about treatments? Because therapies can certainly contribute to fatigue. And in fact, many of our most effective MDS therapies have side effects that include fatigue. Take, for example, lenalidomide or Revlimid. This is a medication that we use to treat a certain kind of MDS called MDS with deletion 5q. One of the major side effects of this drug is that it does cause some degree of fatigue or tiredness. Now, I'll tell you, it's usually not severe enough that we have to change the dose or stop the drug altogether, but it can be quite profound for patients and they can notice it. Ideally, if the drug does its job and people achieve a remission or see improvement in their blood counts, maybe that overcomes the degree of fatigue that they have. But usually people notice that this drug does cause some fatigue. Luspatercept is another drug that we use for people with lower risk MDS to help boost the red blood cell count. In clinical studies where it's been compared to a placebo, there does seem to be some difference in the rates of fatigue there. But it's interesting because even the placebo group has a pretty high rate of fatigue as a complaint, which just tells you that people with anemia and MDS have fatigue in the background, and sometimes they might attribute it to the drug, and sometimes it might just be due to the disease. Then therapies like azacitidine or decitabine, sometimes called Vidaza, Dacogen, or Inqovi. These are a form of very low dose chemotherapy that we use to treat people with higher risk MDS, and these do often cause very profound fatigue. Interestingly, they don't tend to do it right away. So when people receive these medications on a daily basis for about a week or so, they usually don't start to feel that cumulative fatigue until the end of the week, or even perhaps the second week when they're no longer receiving the drugs but are still recovering from the effects of them. So fatigue there is very common also. A newer drug called imetelstat or Rytelo has also been used to treat patients who have very profound anemia, and that drug itself can lower blood counts, just like azacitidine and decitabine and lenalidomide can. And that lowering of blood counts can contribute to that sense of fatigue, just like I described earlier, in the way that anemia and other things can. And finally, the other drug that we use in some situations is called GCSF. You may know it by the names Neupogen or Zarcio. This is a white blood cell stimulator that helps produce more white blood cells to help you fight infections. And this drug itself can mimic some of the cytokines that we have when we have an infection. So it can cause low-grade fevers, it can cause bony aches and pains, it can cause chills. So some people will have these kinds of reactions to this drug, which again can contribute to a sense of fatigue or even mimic it altogether. But one of the bottom lines to remember is that if these drugs are effective, if they put patients into remissions, or if they increase their blood counts in such a way that they actually are no longer as anemic and no longer requiring transfusions, they might substantially improve how people feel. They might see their quality of life get better, and they may feel less fatigue as a consequence of that improvement. So in general, we are listening to what our patients are telling us about their side effects, but we're trying to push through those side effects until we get the patients to be responsive, and that will hopefully make their quality of life better overall. So what can we do to combat fatigue? I want to go back to that study I showed you earlier that described how severe fatigue was compared to other factors, because in that study, they also asked patients what they are doing to help combat fatigue and how effective they find these different strategies. And they were given options like physical activity or taking prescription medications aimed at fatigue, taking vitamins or herbs or minerals or naps or preserving energy strategies. Even things like acupressure, acupuncture, and meditation were included. Healthy eating was included, and counseling and support groups were included. And the bottom line was that there were certain activities that they thought were quite beneficial. So the ones that were considered most helpful or extremely helpful were preserving energy, things what we call pacing, where you save up your big burst of energy for a particular event in the day, seemed to be very helpful instead of trying to go full tilt the whole day. Physical activity was considered to be very helpful, closely followed by napping and taking selective naps, and we'll talk more about how best to do that. And meditation was found helpful by the group as a whole, but not so much by the subset of people who had MDS. It was more useful for the people with other kinds of bone marrow disorders who may have less of this inflammatory process going on. MDS patients did find healthy eating more helpful than their counterparts did, and other things like acupuncture and counseling were not perceived as being particularly helpful. So this is some of the strategies that people employed and how effective they thought they were. But we can also look at what has been shown to help. What kinds of interventions have we looked at in clinical trials or in other studies to help us understand what things can improve fatigue in people with MDS? And there's a whole list of things that can be tried. And one of the ones that comes up most often is this idea of cognitive behavioral therapy, essentially a form of counseling where people get insight into why they might be fatigued and what they might be able to do about it that empowers them to do more. Interesting that in that last study, people with MDS didn't find that particularly useful, but it does come up as one of those interventions that can help people, and I would encourage you to consider it. The second most effective thing on this list is graded exercise therapy. And this idea is that you don't need to do a lot of activity, that even things like walking around the block or even doing the shopping where you're pushing the shopping cart, doing these things on a daily or near daily basis can have really profound benefits. And it's understandably difficult to do if you're feeling very fatigued and unmotivated to get up and do any form of exercise. But interestingly, the people who are able to do that and do it on a regular basis will see their fatigue improve much more than people who just try to rest and preserve their energy. That said, resting is important, and probably the most important kind of rest is getting good sleep. And good sleep hygiene is building habits that allow you to get good sleep. These are things like trying to go to bed at the same time every night, avoiding distractions at bedtime, like books or, more importantly, electronic devices that are shining a light directly into your eyes, and avoiding things that might disrupt sleep close to bedtime, things like alcohol or caffeine, coffee, tea, and so on, right before going to sleep. Those are examples of good sleep hygiene that are really important. That said, naps can be really important as well. And here, short daytime naps seem to be more effective than long ones. If you go to sleep for about 15 to 30 minutes, that can be restorative sleep, and you're not in a deep haze when you wake up. Whereas if you sleep for 45 minutes or longer, that could be enough sleep that puts you in a deeper sleep and then makes it harder for you to sleep at night and get those good solid hours of rest at that time. And in fact, this is what airline pilots do when they have long haul flights, is they take short 15 to 25-minute naps and avoid those deep sleep naps that might make them more groggy and more difficult to get good sleep patterns in the future. Pacing of activities is important, like I mentioned before, saving your energy for those big events, maybe taking it easy in the morning and then having a big burst of activity in the afternoon might be easier than trying to do all the things you need to do in one day. And finally, working with your doctors to address other problems that might contribute to fatigue. So things like heart disease or lung disease or diabetes, if not well controlled, can also make people feel very tired and lethargic above and beyond what any component of the MDS might be contributing to the equation. So addressing those other diseases or disease states can be very important. Maintaining adequate nutrition is important. It doesn't really matter so much how you do it, but we know that people who don't eat enough calories and people who are losing weight will tend to be more lethargic and have more fatigue. So maintaining good nutrition, I think, is really important to do. What kind of nutrition you use maybe doesn't matter quite as much, although there is some evidence that certain diets might be less inflammatory, and maybe those might contribute to that improvement as well. But most importantly, getting enough calories. Other more psychological things like getting good social interaction is important, feeling like you're not carrying the burden of this disease alone. You have help, you have people who can assist you with what you're doing. And there's less evidence for particular supplements. There really isn't a single supplement or combination of supplements that we think is really effective in fatigue, short of someone having a true deficiency of something like B12 or having true thyroid disease that could be supplemented with thyroid medication. In the absence of those unique situations, most over-the-counter supplements are not particularly effective. And finally, keep in mind that response to treatment can be very beneficial for addressing MDS-related symptoms like fatigue. So in summary, remember that fatigue is the most common symptom experienced by people with MDS, and over 90% of people who have this disease across the entire range of severity. It can be caused by the disease directly, but also indirectly through its effects on blood counts and inflammation. Treatments, other medical conditions, and person's own mental state contribute to that sensation of fatigue. And there are things you can do: better sleep, more activity, maintaining your weight, nutrition, mental health care, and ultimately treating your MDS can all lead to improvements in fatigue. But you got to tell your doctor about how you're truly feeling. Describe your symptoms in objective terms to make sure they understand how this fatigue affects you and help them understand how they can best help you overcome it. All right. With that, I'll end. Thank you very much, and I hope we have some time to share some questions.
Thank you so much. That was a phenomenal presentation. So thank you to both of our speakers today. We do have a little bit of time for questions. So if you have a question, please put it in the Q&A. We've also pulled some questions from things that were sent in prior to the webinar that maybe weren't addressed. So we'll get started. So the first question that we have here is hemoglobin is 11.3. Why am I still so tired? They're getting luspatercept. Essentially, how is it helping? Whoever would like to take that.
Yeah, that sounds like an MDS question, so I can try to take that one. First of all, it's great that you have a hemoglobin of 11.3. That's the goal with the drugs like luspatercept. We're trying to get that hemoglobin into a range where the anemia is not likely to be the major cause of symptoms, including fatigue. So if you're able to do that with luspatercept, I think that's a great intervention. But as I mentioned in the talk, it isn't necessarily always the solution to fatigue because a lot of other things will be contributing to that. So this is where you have to look at employing these other strategies, making sure you're getting good rest, making sure you're maintaining good nutrition, making sure you're remaining active and doing exercise and mobilizing so you have more reserve on a day-to-day basis. And it's discouraging to know that a medication that you're taking isn't quite solving the entire problem, but there is more that you can do.
Great. The next one is about iron. I know we talked about low iron a lot in causing fatigue, but this person has high iron levels. And so I guess they're wanting to know, does that contribute to fatigue? And then maybe what are some ways that they can keep it from going higher? So I think
I guess I
either.
can start. Certainly, iron overload is something that is seen in both MDS and myelofibrosis patients who get a lot of blood transfusions, which leads to iron overload. So it depends on the degree of iron overload, and typically the doctors are monitoring this. Potentially, it could contribute to fatigue, but as I think you heard from both of us, that it's the fatigue here is usually multifactorial, meaning there's so many different factors that are contributing to it. So it's hard to know sometimes which is the exact reason for fatigue. So um, iron overload potentially can cause fatigue, or it can be one of the things that can cause fatigue. There are medications that can help lower your body's iron levels. And sometimes they're used and sometimes they're not. I think it just depends on the overall clinical picture.
Great. Anything to add for that, or we'll move on to the next one.
No, I think that's a great answer. We can move on.
All right. So the next one is, at what point does tiredness become fatigue? So I guess the difference between the two, which I think was addressed, but if you anything to say to that.
Yeah, I don't know the exact answer, but I think that if you feel tired and you're able to get some rest and you feel recovered, then that seems like a more normal pattern of exhaustion and recovery. Whereas if you feel tired, but there really isn't anything you can do to fix that problem or restore that feeling of normal energy, then that sounds like more like a chronic fatigue type scenario. So I think really the degree of impact that it has on your life is what makes that distinction for me, whether something is an issue or something is just part of a normal behavioral routine. How much does it affect what I want to do and what I'm normally able to do?
Yeah, it's great. The next one is, I mean, I don't know how you want to. I yawn more than I used to. Is this to be expected? So
I
it
don't know
comes
if
with.
I know the answer to this question.
I have heard that it can be a sign of like needing more oxygen, like you're taking a deeper breath when you yawn, but I don't know if there's really a scientific connection to that.
I think there are a few theories about why we yawn, but I don't think it's really actually well defined in general. Some of it is sort of communication of the brain, um, um, sort of communicating the different wake states. It has to do with some of the neurotransmitters in the body, but honestly, these are not, I don't think anybody really well understands what yawning actually means, as far as I know. I don't know if Dr. Behar has a better answer for this.
No, I agree with you. I don't think we really understand what the implications of just more yawning might be, but I think if it is associated with feeling more tired or wanting to rest at times when you don't normally, then it could be a component of fatigue that's manifesting itself that way. But hopefully, if that's the only symptom, it's not too bothersome.
Sounds good. The next one is I get overwhelmingly sleepy a short while after eating. Is my body sending blood to digest the food instead of powering my brain.
Yeah, that may be an accurate description of that. I think this is very common to have this tiredness after eating, even in people who don't have MDS for sure. Think about that post-Thanksgiving dinner sensation that you have after eating the large amounts of turkey. So there is a commonality to that. If you're more vulnerable to that because you have an underlying disease that's already got you at the edge of a fatigue state, I could see that it might happen more often or it might be more noticeable, even when you don't have necessarily a large meal. So I think that's kind of normal and occurs, I think, frequently for people who have MDS. And maybe the issue is that you're shifting your resources towards digestion and rest instead of activity and energy at that time.
Good. Next one is I get this question a lot, by the way. My husband has MDS and benefits from low dose Ritalin, 5 mg, 1 to 3 tablets daily. What's your opinion on using Ritalin for fatigue?
Yeah, I'll answer this, but I'd be curious to hear Dr. Kermanskay's answer as well. We actually don't use pharmacologic stimulants very often in treating MDS-related fatigue, but it doesn't mean it doesn't have its place. There are certain people who really do benefit from these medications. And part of what we do for people who do have profound fatigue is have them meet with our palliative care physicians who would do a more global assessment. And often they are the ones who are recommending the use of a stimulant medication like this because, like I said, it can be helpful. But in other people, it doesn't necessarily get at the root cause of the problem. It's not treating the disease, it's not treating the inflammation. It's just trying to provide more energy, but sometimes there's trade-offs with that aren't necessarily worthwhile for some patients. So it can have value, but I think it has to be in the appropriate setting.
Yeah, I agree completely. I mean, I don't typically use these drugs myself, but work with colleagues such as palliative care, psychiatry sometimes, or geriatrics occasionally. And then if looking at sort of holistically at the patient, if we think that might be of benefit to a particular patient, I don't see why not try it. So if it works, great.
All right. We do have a question it goes with fatigue, but a little bit outside of that too. So, patient with SF3B1 mutation, they're on Reblozyl every 3 weeks, using labs to determine whether or not they get the injection. Is there benefit in weekly lab checks outside of what's required for the every 3 weeks?
Yeah, so Reblozyl or luspatercept is an injection that's typically given every 3 weeks. And we check your blood count before you get that injection to make sure you're not already at a place that we're trying to get you to. So if your hemoglobin is typically over 11 or so, or 11.5, we'll skip that dose that day. And then the question is, should we be checking weekly instead of every 3 weeks to know when is the right time to give the injection? And there is some value to this because if you just skip that dose and you don't come back until your next appointment 3 weeks later, it's possible that your hemoglobin could fall during that time to lower levels than you would like it to. So when I encounter that with my patients, if it happens a few times in a row, I actually consider just reducing the dose of luspatercept so it's less likely to happen. But alternatively, I'll say, well, you don't get the injection this time because you're above our target hemoglobin. Why don't you come back in 1 week or two instead of waiting the full 3 weeks to recheck to see if you meet the criteria at that time, and then we can give you the injection. So that can be helpful so you don't have to go that whole 3 week cycle with lowering blood counts during that time before you get your next injection.
Great. This is a really great question, I think. Does length of time having the disease affect the fatigue levels? So how long you have MDS or MPN, does that correlate to the fatigue?
I'll be interested in Dr. Kremenskya's experience as well. I think yes and no. I think there are some people who really notice fatigue from the beginning, and it's even when their disease isn't particularly severe or even requiring treatment. And then there are other cases where certainly there is an accumulation of factors over time, whether it's treatment effects or whether it's progressive disease and worsening blood counts that do contribute to the sense of fatigue. So it's not always the case that everyone who has fatigue today is going to have worse fatigue tomorrow. And it's not always the case that people who don't have fatigue today will have worse fatigue tomorrow. But there is a trend towards more fatigue over time.
Yeah, I think I agree. I think as patients have diseases for longer, the fatigue maybe accumulates to a degree from treatments and just the stress of dealing with the disease. But on the other hand, first of all, there are people who have severe fatigue at diagnosis, and then as they start treatment, they feel better. There are also people who kind of figure out how to deal with their disease and find ways of dealing with the fatigue and other symptoms and actually feel better over time because they know how to manage it. So I think it's just we see really different things, and it's very, very individualized.
A good point. Um, so next question is, I experience fatigue, but my physicians always discount my symptoms. And then they talk about being, having multidisciplinary healthcare teams. How do you get them to work together? If it's multifactorial and you're seeing multiple specialists, what would be your recommendation?
That's a good question. I said in the talk that it's sometimes helpful to relay how you feel in more objective terms that the doctor can put their finger on. If you say that I feel more tired or more fatigued, that it's difficult to quantify that. But if you talk specifically about the things that you can't do anymore or that really give you a hard time, uh, that may be easier to hold on to. And then your other question was about getting teams to work together. I think that is very important. And I think well, one of the things we teach patients at the MDS Foundation is to really be advocates for themselves, that if they're having questions that are not being answered by their physician, or if they have questions that they might need help from elsewhere, that they should seek those out. Sometimes it can be helpful to get a second opinion, for example. But ultimately, you can just tell your physician, these are the things that I would like. I'm not seeing enough coordination between you and my psychiatrist, for example, or between you and the palliative care patients, for example. Is that something that we can do a better job of communicating with? You should just ask for what you need.
And I think today, this day and age, it is in a way, everyone is very busy. There are so many different ways that you can communicate with the physicians and they can communicate with each other. So I think if it's very important to you, and I think it should be, like if you feel that you're getting different answers from different physicians or different members of the care team, and you don't know how to manage that, you can say, I really would like you to get in touch with this particular team or this physician. How can I help you do that? Can I put you both on the same email? Is there a way that I can help facilitate that? And so maybe that will make it easier for the doctors to get together because sometimes, patients will ask me to speak to another physician. I call the office, I leave a message. They don't call me back, and I move on, not necessarily following up, and then I feel bad about that. But there's so many things that you need to do, right? So if there's an easy way to get people together, if you can find that way, that will help you get the answers that you're looking for.
Great point. So just a quick reminder, we do end at half past the hour. So if we do not get to your questions, we will compile a list and try to get to them after. I think we have time for maybe just a couple more. There was one specifically for Dr. Bejar, and they're wanting to know if the patients in the studies that you presented were screened for depression and if that could be contributing to fatigue symptoms as well.
Great question. I think in the first study, there was no screen for depression. These patients were given these questionnaires that included elements about depression. And the total result was that the depressive symptoms were relatively mild, particularly compared to the fatigue symptoms. But you are absolutely correct that depression is something that people are more vulnerable to when they have MDS and will certainly contribute to their overall well-being. Not just their symptoms of fatigue and other things, but it actually seems to correlate with how well they do with treatment, even. So it is an important thing to address that I think is distinct from fatigue. But they do certainly have overlapping features.
Great. This one can apply to both. So does fatigue, increasing in high fatigue correlate to sooner disease progression, to leukemia? That one came in prior to the webinar, so let's see if we could answer that one.
Is the question if worsening fatigue can signal a sign of disease progression?
I think so, yeah. Does high
Okay.
fatigue mean conversion to leukemia is more likely or that it's more likely to happen sooner?
I certainly often there is an increase in what we call systemic symptoms when there's conversion to leukemia. So, for example, night sweats, fevers that are not actual infection, just overall worsening malaise and feeling worse and fatigue is a big part of it, can be a signal of progression to leukemia. But also sometimes, we just find that by looking at the blood counts that something is going on and patient says, I feel fine. So I don't think there's not necessarily direct correlation. In fact, I think often with both, I think myelofibrosis, which is, the more advanced form of MPN, and MDS, especially when patients have super low blood counts, this is when we really hear a lot about fatigue. So I would say yes and no. I don't think there's a direct correlation.
Yeah, in AML, this has been looked at where the severity of fatigue-related symptoms does correlate with the severity of disease, which in some senses makes a lot of sense. And even in blood cancers in general, I'm thinking about lymphomas now. One of the ways that we grade lymphomas is we talk about how many fevers, chills, and weight loss people are experiencing. This is a consequence of those inflammatory cytokines that are being produced by disease. So it is an indirect measure of how active the disease can be. It doesn't mean that your disease is severe, that you're going to have worse outcomes necessarily, but it does mean that your disease may be more inflammatory and resulting in these phenomena, and should be considered as part of the way that it's affecting you and the decision to treat.
Great. So definitely great presentation and great questions. And like I said, we'll try to get answers to everyone's questions if we didn't have time during this live session. I want to thank everyone for joining us today and for engaging on this important topic. Please know that the MDS Foundation is here for you. And if you ever need support or resources, you can always reach out to us. The phone number is 1-800-637-0839. You can email us at support@mds-foundation.org, and I'm sure Peter would feel the same. So if you ever have any MPN questions, we can definitely get you his contact information as well. Janice will be sending out an email at the end of the webinar with a brief evaluation. We would greatly appreciate your feedback. Again, thank you to our speakers, Dr. Bejar and Dr. Kamienskaya, and to Peter Lawfulhart of the Global MPN Scientific Foundation. Also, thank you again to all of our sponsors and people who have donated over this past year. This concludes our webinar program, and it also concludes our webinar series for 2025. We look forward to seeing you next year.